Anemia Mukti Delhi, and speaker is Dr. Manju Puri ma'am. Ma'am is a great teacher. She's admired and adored by all her students. And ma'am is professor in the Department of Obs and Gynae at prestigious Lady Hardinge Medical College, Delhi. We have experts with us in the meeting. Dr. Sharda Jain ma'am. Ma'am is founder secretary general of Delhi Gynae Forum and director of Life Care. Dr. Asmita Rathore ma'am, director and HOD Department of Obs Gynae at Maulana Azad Medical College, Delhi, and president of AOGD. Dr. Sangeeta Gupta ma'am, is ex-HOD Obs Gynae at ESI PHIMR Basadapur, Delhi, and she is a founder secretary of Delhi Gynae Forum. Dr. Sonal Batla ma'am, she's a senior consultant of Gynae Sant Parmanand Hospital, and she's president of Delhi Gynae Forum Civil Lines. Dr. Mrinalini Mani ma'am is head department of Obs Gynae, Guru Gobind Singh Government Hospital, Delhi. She's a past president of DGF Southwest. Dr. Sadhana Gupta ma'am is Foxy presidential candidate for 2023. She is an IGF president and vice president of Foxy in 2016. Dr. Jyoti Bhaskar ma'am is a consultant at Cloud9 Hospital. She's president of Delhi Gynae Forum East and co-chairperson of AOGD Subcommittee on Quality Improvement and secretary of Delhi chapter of Indian Menopause Society. Dr. Kiran Chabra ma'am is senior consultant Obs Gynae Director Chabra Medical Center Pitampura, and ma'am is vice president of Delhi Gynae Forum Northwest. Welcome all the experts and speaker. Over to the Dr. Manju Puri ma'am.
Yeah, thank you, Meenakshi, for a kind introduction, and thank you, Dr. Jain, for having me here and talk on this very, very important topic. So I'll be sharing my slide.
Cancel what I was.
Wonder what sound is coming.
Red X up there, and I'm going to show you a shortcut that Excel has, and depending on the computer you have and the particular operating system and the version of Excel.
Dr. Jyoti, could you please mute yourself? And can someone tell me whether my slides are visible?
Yes, ma'am. Yes, ma'am.
Your slide is visible.
All right.
So yeah, we can see.
I'll have to go back just a second. I can't move them. I'll just share them once again. Yeah. Yeah. Is the screen visible now? Can I just start?
Yes. Yes, ma'am.
Yeah. All right. So anemia, we all know, is a chronic problem. Chronic as of that, we've been trying hard to fight it out, and with a whole lot of programs in place, still, there is nothing which has happened. So with that in mind, a series of webinars have been conceived by Dr. Sharda Jain. This is second in that series, and I'll be sharing my thoughts on what is the roadmap to Anemia Mukt Delhi. So Anemia Mukt Delhi is what we have been talking about ever since we took over Narchi last year in March. Now, anemia is a silent epidemic adversely affecting the health of individuals and economic growth globally. It is world's second largest cause of disability, responsible for 1 million deaths per year. The physical and cognitive losses due to anemia cost the developing countries up to 4% loss of GDP. So it is not only the deaths, but it is a whole lot of, long-term health issues and economic losses. So anemia reduces the physical development in the form of decreased, work output, decreased work capacity, and that is how economic losses. It results in impaired sexual and reproductive development, leads on to irregular menstruation, low pre-pregnancy iron stores, low birth weight babies, and preterm delivery, with its resultant long-term effects, then reduced cognitive development, diminished concentration, disturbance in perception, and poor learning ability. So all this collectively would cause much more damage, what we are actually seeing. Now, a lot of national programs to prevent anemia have been put in place by Government of India. It started way back 50 years back, is a time in 1970 when the National Nutritional Anemia Prophylaxis Program was initiated. Then its name was changed. Then came the National Iron Plus Initiative, NIPI, where the beneficiaries network was increased. And then in 2018, Anemia Mukt Bharat, in collaboration with intensified NIPI and Poshan Abhiyan, was launched. However, the mainstay in all these programs have been iron and folic acid supplementation. Now, this is what was there, which was rolled out in 2018. We did have COVID in between, and understandably, it did not get the push which it actually needed. And the target in this program in 2022 was to reduce the prevalence of anemia by about 12 points in each of the categories. So if we look at pregnant women, that time in 2016, it was 50%. And the aim was to reduce it to 32% by 2022 by 6 strategies. So very clear strategies were there. And with those, it was expected that it will come down to 32% in pregnant women and 40% in lactating women. And of course, in all the other categories too. So if we look at an NFHS 5, which was carried out in 2019-21, we see that, in Delhi, per se, there was a slight reduction to 42.2 from 46.1. But overall in India, if we look at the prevalence of anemia in pregnant women, it increased. It increased to 52.2%. So that means somewhere whatever we are doing is not working. So if we do what we have always done, we'll get what we have always got. So if we want different results, then we have to think differently. So it's time to think beyond IFA supplementation. So what do? There are other micronutrient deficiencies like vitamin B12, vitamin B6. We need to think of other routes of iron administration. We need to think of behavioral changes in healthcare providers and beneficiaries. Focus counseling on intake of iron and calcium tablets and dietary advice. Checking compliance at each visit. Involving family members, especially spouses. So right now, what has been happening is it has been a top-down approach. There is a policy which is disseminated and everyone is supposed to follow it. But I feel that we should now go for a bottom-up approach, because we need to actually go to the frontline workers and find out as to what is it, why is it that we are unable to make a dent. So it has to be basically a combination of the two. So we need to do sensitization and empowerment of the frontline healthcare providers to identify the gaps and plug it. And also sensitization and involvement of opinion leaders, general public and media. So that means we have to make a lot of noise. So if I look at the roadmap to Anemia Mukt Delhi, I feel that the basic, the pillar would be identification of gaps in implementation of the programs by the frontline healthcare providers and plugging them with quality improvement methodology. We have very good programs. The thing is, the problem is in the implementation. And where does it fail? It fails at the periphery. So we need to look up and talk to, engage with the frontline workers and find out as to what can be done about it. So a word about quality improvement. When I use the word quality improvement, it is a set of focused activities which are designed to monitor, analyze, and improve the quality of processes in order to improve the health outcomes. And here a health outcome is prevention of anemia. So we need to identify what are these focused activities going to be. So using quality improvement methodology for reducing the prevalence of anemia in pregnancy, this is a point of care quality improvement methodology. It essentially has 4 steps. So by quality improvement, we break a complex problem into small parts and then fix up each of the parts so that the changes which we bring about are consistent and constant. So we identify a problem, write an aim statement and form a team. Then we analyze the problem and measure, identify the outcome measures, because if you don't follow your outcome measures, then you would not know whether your interventions are effective or they are not effective. Then the third step is developing and testing changes by using plan, do, study, act cycles. And the last step is sustaining improvement. So when we do in-depth analysis, I'm to say we know that the programs are not working, but we need to do in-depth analysis for the reasons why we have not been able to make a dent in the prevalence of anemia. So there are certain tools which I would like to introduce you to. These are helpful in analyzing any problem. So one is a process map, one is a fishbone analysis, then 5 whys and Pareto principle. It's just an introduction so that you can understand what it is. So this is a process flow chart. Now, if I look at the process flow chart, this is one way of, our patient comes to the OPD. This is the process flow chart, example of a process flow chart of what happens in our OPD. So the guard sends the woman inside the OPD, the clerk notes down the name and sends the woman to the nurse for a BP and weight. Then the nurse checks her BP and weight and sends her to the obstetrician for examination. And there's a technician sitting there who does a spot hemoglobin. So I made a cloud here because we are not sure who gets hemoglobin done and who sends. So this part was not clear. Then after the doctor takes the history and examines, she looks at and, she will see if the woman is looking pale. She would prescribe a hematinics and then send her back to the technician. So not everyone, the obstetrician does not have the report there on her to know whether she's actually anemic or not. Then the woman returns to the obstetrician to show the report. This is again in a cloud because some of the patients would go home. They would not come back. Some of them would not get a hemoglobin. They are in a hurry, so they go home. And if the patient comes back to the obstetrician, she would then alter the dose of the hematinics. And then the patient goes to the pharmacy to collect her tablets because they are available free of cost, because the pharmacy was at some distance away. So some of them would take the medicine, some of them would not take because there were no directions to tell them that this is how they have to go. And then the woman goes home. So we know there are 3 places where, things need to be modified. So this is how the process flow works. So at every place, one can make a process flow chart like this. Now, this is a fishbone analysis or Ishikawa chart, we call it. This is a Japanese professor of engineering and also a quality guru. So he's the one who proposed it. He said most of the causes are related to either policy or people or place or procedure. So in our case, this is again the example from our hospital that women, as far as policy is concerned, women were not offered hemoglobin test at 28 and 36 weeks. Albendazole was not prescribed. CBC was not ordered for all pregnant women in the first visit. CBC with peripheral smear was not ordered for women with mild anemia. Everyone used to neglect it and no information pamphlets were available. As far as procedure was concerned, many women went home without getting hemoglobin done. Many went without showing the report to the doctor. Many went without collecting the medicine. So this was a procedural problem. As far as the people were concerned, healthcare provider did not advise hemoglobin test as per GOI guidelines. Only once it was done, then maybe at 36 weeks. Then mild anemia was not flagged at all. Everyone was comfortable with a hemoglobin of 10. Anything less than 10 was worrisome. 10 plus, everyone was comfortable. Lab technician was not available at all times. Women did not get their hemoglobin done or show the report to the healthcare provider. They did not collect their medicine and take as per prescription. Pharmacists did not dispense the medicines as per prescription. So a whole lot of problems. Then as far as the place, there were no directions for reaching the lab tech or pharmacy. Pharmacy was away from the OPD and beneficiary flow was not unidirectional. So imagine so many things came up when we looked up that why is it that our women who were booked in our hospital had more than 4 visits, but when they came for childbirth, 50% of them were anemic. Then we have something which is known as 5Y. Now, when we talk about fishbone analysis, it gives you a wide spectrum of causes. 5Y helps you go into the depth. So say the question is antenatal women were not taking iron tablets as per prescription. So we ask, why are they not taking? So the answer is because they were not getting the right number of tablets. So why are they not getting the right number of tablets? Because nursing officer is not dispensing the IFA tablets as per prescription. So why is the nursing officer not dispensing it per the prescription? Because they have only 2 types of ready-made packets. One had 30 tablets, one had 60 tablets, right? So they would just give one of the packets as per hemoglobin level documented on ANC. So we ask them to make multiple packets. Some patients are going to come back after 1 week. Some are going to come after 2 weeks. So once they started making those multiple packets and give it as per prescription, the patient would now take it as per prescription. The last tool is Pareto principle. Now, this is a very interesting principle. This was brought forward by an economist who's Wilfredo Pareto. He's an Italian economist. He said that most of the causes, 80% of the causes can be corrected by 20% efforts. So he said that we should, if there is a problem which has multiple, reasons, then you should put them in the descending order. Say, for example, say many pregnant women are not getting their hemoglobin done. So we looked into that. So why are they not getting their hemoglobin done? So majority of the times the technician was short of microcubics, so he could not do it. In another 30%, a technician was not on the seat because, the patient would go to him after the doctor had seen. So he would go for his lunch, or maybe he was not there at certain times. Then 10% doctor was not prescribing. And in 7%, doctor prescribed, but did not tell the patient to go to the lab technician. Okay. And in 3%, patient did not reach the technician because she got lost. So here, if we would focus on the lab technician, we will get 80%, rise in the hemoglobin assessment. So this is what is Pareto principle. It is a secret to success by achieving more with less. So now how to select which problem to fix first? We have listed so many problems. So we must always try and pick up problems which need low effort but have high value. So these are the ones which are due now. So we call it as that we should pick up the low hanging fruits first, because it will start giving us results and will keep the team motivated. So any problem which has got high value or impact but low effort, needs low effort and is easy to fix, is the one which should be picked up. All those which are low value and need high effort should be, we should not focus on them. We should focus on the ones which are due now. So I'll share my, it is not mine, it is our QI project on reducing prevalence of anemia in LHMC. We started this project way back in, June 2021. So we are more than a year, 1.5 years back we started. So first of all, we collected our baseline data. It is important that you must have a baseline data, because then you would know how much change you are going to make, and are you improving, are you not improving. So we collected it from a Lakshya register. So in our booked pregnant women, the anemia was 45.2%, and in unbooked, it was 82.3%. So because unbooked was not in our control, so we focused on the booked one. So the first step was to make our aim statement. So we aim to reduce the prevalence of anemia in booked pregnant women admitted in labor room for childbirth from 45.2% to 30% in 4 months, starting from 1st June 2021. So that is what was decided. So then, your aim should have all these components. What are you going to do? You're going to reduce the prevalence of anemia. In whom are you going to do? It has to be booked pregnant women admitted in labor room for childbirth. By how much? From 45.2 to 30%. In how much time? 4 months. Starting when? 1st June. So this is a smart aim. It has all the components. Then this was the flow chart I've already told you. So we made a flow chart as to what is happening as far as the hemoglobin estimation and treatment is concerned. Then this is our fishbone analysis. So we made a team. The team had consultants, had a senior nursing officer of the OPD nursing officer, residents, registration clerk, lab technician, guard, meaning that all those who are involved should make a team. And when they work together and when they succeed, I'm to say it's everyone gives their input. So we know what is happening where. And then each one is motivated. So you must have a team which represents all the people who are involved in the management of that particular issue. And we identified our outcome indicator. So outcome indicator has to be very clear. The whole team should know what are we looking at. So it is number of booked anemic pregnant women who have a hemoglobin of less than 11 gram% divided by total number of booked pregnant women birthing in the unit. So thus we have to know where are we going to collect this data from. It was labor room Lakshya register. Frequency of collection was weekly, and the recorder was a resident. So there are many interventions. The interventions were selected based on the problems which we had listed in the fishbone. So we started, the interventions which we did was mandatory hemoglobin testing in all women at registration as per GOI guidelines. So we did it 3 times. Registration visit 28 weeks, 36 weeks. Flagging of anemic women by lab technician. So lab technician was given small flags. So anyone which was less than 11 gram%, he would put a yellow flag so that everyone knows that this is an anemic woman who's coming to her. Then flagging of all women at 28 weeks by registration clerk, because we saw that we were not doing any hemoglobins at 28 weeks. So we thought that let the registration clerk mark that these are the patients who are at 28 weeks. So any patient coming in 8th month was sent for a hemoglobin and then sent to the doctor. Ensuring continuous availability of point of care hemoglobin estimation. So 2 digital, hemoglobinometers were made so that if one goes out of order, there is another one. Then the lab technician used to go for lunch. Nothing was accountable. So he had to arrange we decided to have a replacement there so that no one goes without hemoglobin assessment. Then sensitization of all doctors on additional investigations like CBC with peripheral smear for all the patients who are anemic. Even if they are less than 11 gram %, it is much better because we would know in case there is any other deficiency other than iron. Serum ferritin, B12, folic acid, and HPLC wherever indicated. So CBC with peripheral smear was for all as the first investigation, rest all based on the peripheral smear. Then sensitization of all doctors on additional counseling of iron and calcium intake, because people were taking them together anytime they would take it. So, we told them there has to be a gap of, 1 to 2 hours between iron and calcium, and dietary counseling and deworming for all women. Then we set up an anemia room to focus on women with moderate anemia between 28 and 34 weeks, because that is a time we thought that we can, if they were already booked with us and their hemoglobin is not improved, then we might as well give them parenteral iron. So they were sent to the anemia room. Then ensuring continuous availability of iron tablets and deworming tablets in the OPD. So the sisters were asked and taught how to keep a buffer quota, and never should the iron and folic acid tablets go out of stock. Ensure continuous availability of hemoglobin testing during the OPD hours. Proper prescription and dispensation of hemetinics. Sometimes iron tablets would come which had different elemental iron. So we asked people to prescribe elemental iron and then asked the sister also to look it up and give it in the right dosage. And administration of parenteral iron after doing serum ferritin in those with moderate anemia between 28 and 34 weeks. That was our focus group. Additional provision of vitamin B12 tablets in OPD. Then administration of parenteral vitamin B12 and folic acid in OPD. And repeat hemoglobin 4 weeks after prescribing hemetinics. We were not following that. Then, because there are shortage of beds and the number of patients are more, so line listing and staggered admissions for parenteral iron. So we would put their phone numbers and call them as and when the ferritin reports would come, and call them for injectable. So all these interventions were introduced. And this is what happened after the, flow chart after the intervention. So women reached the OPD for antenatal visit, guard would send the patient to the OPD, registration clerk would, do the registration, send to the nurse. The nurse would now identify those who were at 28 and 36 weeks and first visit. She would make sure that they were directly sent for hemoglobin. Technician would do the hemoglobin and put a colored identifier that this is the patient, and also have a dietary advice chart he would give to the anemic woman, who would then take it to the doctor. So then the doctor would screen and see whether the hemoglobin is done. Sometimes the patients went without hemoglobin, then the doctor would send them back to the technician. So, and then we shifted the dispensing of pharmacy in the OPD only. So the woman, after the doctor had seen, so she would be given proper advice, and her CBC and other things would be done. And then if she was 28 to 34 weeks with a hemoglobin of less than 10 gram %, she would be sent to anemia room so that someone would take charge of her and prepare her for parenteral. And then she would collect the medicines from the pharmacy and would leave for home. So this is what was the flow after we finished with her. And so after the interventions were put in. So these were the charts initially, they were in English, then we put some Hindi titles to it so that she could understand. So this is what happened. This is our time series chart. So initially you can see the median was here at around 50, then it came down to about above 30, but it was here, then we thought of giving parenteral iron. This was almost after 6 to 8 months, we could not reach our target. So then we came with that intervention of giving parenteral to all those who were between 28 and 34 weeks, and we reached our target. So we stayed at about 22% here. And again, it went up. So I'm to say, tracking this helps us know whether things are in place or they are not in place. And another interesting thing was, although we had about 25% still who were anemic, but if you see here, The blue line shows mild anemia and the red line shows moderate anemia. So there were more patients with mild anemia and there were lesser patients with moderate anemia. So it is because we took the cutoff as 11. So that is why we still had 25% patients who were anemic. So a word about vitamin B12 deficiency. So in this project, when we saw a huge number of patients who had vitamin B12 deficiency. So vitamin B12 deficiency in Indian women during pregnancy range between 40 to 70%. It is more in northern and western part of India. With the advancement of pregnancy and increased fetal demands, the concentration of B12 in the blood falls and the proportion of vitamin B12 deficient women increases. That is why there is a crash fall. If your patient is taking hematinics religiously and her hemoglobin falls or does not improve in the last trimester, think of B12 deficiency. Babies who are born with B12 deficient mothers are also B12 deficient. And vitamin B12 deficiency in anyone has a lot of harmful effects. So although it is widely prevalent, vitamin B12 supplementation is not a part of public health policy in India. And I think high time that we start looking at that. So this is a study which was conducted in our own hospital. So this is the data from 100 patients who were registered at the first visit, and we took their hemoglobin, their B12 levels and their folic acid levels. Interestingly, 60% of them were B12 deficient. And at the same time, 97% of them were folate replete. So imagine, we keep giving them iron, folic acid, but we don't think of B12 at all. So now looking at what are the features of vitamin B12 deficiency. It is very subtle. It is like any other patient of anemia. There would be fatigue, pallor. Jaundice is additional. Glossitis again tells you that there are multiple deficiencies. But I think we need to focus, and even peripheral neuropathy and neuropsychiatric disturbances, we don't come across these because these are in more chronic patients. In our pregnant women, they become B12 deficient because the increased requirement due to pregnancy. So initially they may be borderline, and in pregnancy they dip. So hyperpigmentation, knuckle hyperpigmentation is something which is a very important feature of it. And then if you look at the investigations a little more carefully, you can pick up. So if MCV is more than 100, sometimes in a patient who is say 8g%, her MCV is 92 or even above 90, it would mean that she's got some more deficiency other than iron. So, a lot of clues come out of it. Then the peripheral smear showing macrocytic or dimorphic and sometimes even normocytic normochromic picture would mean that they could be B12 deficient. Hypersegmented neutrophils, coexistence of thrombocytopenia or leukopenia, evidence of hemolytic jaundice. If you do vitamin B12 levels and less than 200 is definitely a deficiency, but 200 to 300 are also borderline. So these are the patients who would need vitamin B12 supplementation during their pregnancy. So this is an interesting ICMR STS project which we did. So we were thinking that it may not be cost effective to do vitamin B12 levels in all our patients, in the first visit to pick up all those 60%. So we took up 250 random pregnant patients. They were assessed for the presence or absence of knuckle pigmentation, hyperpigmentation, their hemoglobin, folic acid and B12 levels. And very interesting findings came. Out of these 250 patients, 52% were anemic. It is in line with what the government says. But 73.1% were vitamin B12 deficient of these anemic patients. So that means we don't treat these patients. Knuckle hyperpigmentation and anemia. If we combine these two, 86.3% were vitamin B12 deficient. Then clinical pallor and knuckle hyperpigmentation. If patient was clinically pale and she had knuckle hyperpigmentation, 92% were B12 deficient. And women who had dimorphic anemia or any macrocyte in case on their peripheral smear, 94.7% were B12 deficient. So imagine we don't give B12, no? So such a big group of patients is untreated. So if it is untreated, how are we expecting that the women would be free of anemia when they deliver? So we concluded that knuckle hyperpigmentation and macrocytosis in women with anemia can diagnose vitamin B12 deficiency in more than 97% of pregnant women in an affordable manner. So this is a meta-analysis, systematic review, which you must see. See how many conditions are related to low levels of vitamin B12, right? It is not only pregnancy related, but even long-term, a poor cognitive development, higher adiposity, insulin resistance, a whole lot of problems are related to vitamin B12 deficiency. High time that we start looking at vitamin B12 deficiency in our population. So just an example of how do you diagnose it. So this was a patient who had come to us. She came to us in June, right? That was the first registration visit. She was 10.1 gram %, but MCV was 92.4. So, and MCH was low, that was 27.5. So, she came after a month, she was given iron folic acid, her hemoglobin fell down to 9.6. So that is a time when the doctor also got a peripheral smear done. It showed a dimorphic picture. So probably, again, iron folic acid was continued. And after 2 months when she came, her hemoglobin fell down to 9.2 gram % now. Okay, so that's the time when her serum levels were done. Her ferritin was 42.8, B12 was 304, folate was 13, HPLC was normal. So here they thought that B12 is normal, folate is normal. So ferritin was 42.8. So she was given parenteral iron because she was 28 weeks here. Again, no B12 was given to her. And then she came to us after another month and she was 9.4 gram %, a slight rise. And because now erythropoiesis had increased because of, more of iron supplementation. And within a month, at 36 weeks, she was 8.9 grams. Now imagine she's been with us, but somehow we missed all the indicators of giving her vitamin B12. And we ended up having a moderate anemia despite her coming to us regularly. So this is a case where we failed. So failure is not the opposite of success. It is part of success. So if we can interpret it and we can learn from it, I think it will help us improving further. So treatment of B12 deficiency, I need not go into the details, but there is a lot of variation. I'm saying you can give it oral, you can give it parenteral. Majority of patients are not pernicious anemia. So you can give them oral, provided there will be compliance. Otherwise, a single shot of vitamin B12 is sufficient, 1000 micrograms. We did a study wherein we gave only one shot. Now, vitamin B12 is stored in the liver for more than 400 days. And in pregnancy, if you give even a single shot or maybe 2 shots, that should be good enough for the patient. And here the patients were given a single shot, and after 4 weeks, the hemoglobin showed a significant increase, B12 level showed a significant increase, and MCV showed a significant decrease. Everything was statistically significant. So I'm to say, if we think our patient is not going to come back, especially in public healthcare settings, we can give them one shot right in the OPD, and that is what we did in our QI project. So this is a success story. So this patient came to us with a hemoglobin of 7.3 gram %. So that was the first visit, although she was at 28 weeks. So we asked her, she said she will take it orally. And when we did a ferritin, it was 25.3. That was done as a routine. But then because she said she will take orally, then we asked her to continue, and she became 9.8 after a period of about 1.5 months. And then after another 1 month, she became 12.1. So this is a success story, provided you look at it and you counsel the patient and ask her to take the right. So the practice, we need to practice the philosophy of continuous improvement, get a little bit better every single day. So these were a lot of, that bottom-up approach. We did a lot of, contact programs with ASHA workers. And interestingly, when you would ask them, what is the level at which you would think the patient is anemic, everyone said 7 gram %, because they do a line listing at 7 gram %. So we interacted with them. We asked them to do their own hemoglobins and make it 12 and then get it done for their patients. So, all the hospitals came. We had people leading, Dr. Mani from Guru Gobind Singh, then we had Dr. Poonam from Sanjay Gandhi, Dr. Anita from Hedgever, then, DDU, Dr. Sushma from, not Dr. Sushma, Dr. Shashi from DDU. And this is our own Kalyanpuri center with Lydia. So we have trained about more than 400, 500 ASHAs. Then we thought that this is a very slow progress. So that was done over from April till, August. Then we thought we had Narshikon, which was there. Then we did a training of trainers. So Dr. Jyoti Sajdeva and Dr. Vandana Bagga, Dr. Monica Rana all came forward. So we had people from government and private hospitals, including Ayush and homeopathic doctors. They were trained and they were provided with an anemia toolkit. So we had Dr. Swati, Dr. Shilpi, all these people, they got together, they prepared the slides. Dr. Kanika was there, so they prepared the slides. And we have a set now, we have given it to all the people who were there, and we've asked them to cascade it. And go and train their frontline workers, ask them, train them in QI, ask them to fix their own problems. Then 14 December, Dr. Ashla Batra had taken the lead, and we had another, NARCHI event, Anemia Mukt Delhi, turning vision into reality. And, we talked about it. We had Dr. Sharda Jain and Dr. Kamal Bakshi there, and we talked about our vision and shared our views with many people. And then came Dr. Sharda Jain's initiative, where she planned a series of webinars on 9th of each month, starting on 9th December. And she said that we'll have it every month, and we'll continue having, and keep on adding more and more ambassadors for the cause for prevention of anemia. So nothing is impossible. The word itself says I am possible, but to have a focused, target, to reach our target, we have to be patient. We have to have patience. We have to be persistent. We should have perseverance. We have to be passionate, and we have to be very purposeful. So this is my favorite quote. I'll end it with that a small group of determined and like-minded people can change the course of history. And for faster results, we need linkages, we need teamwork, we need to onboard more and more champions. And obstetricians and gynecologists need to take the lead for Anemia Mukt Delhi, because they are the ones who get in contact with the whole family and with the newborn even before the baby is born. So I think we really need to, get together and move towards fulfilling our dream of Anemia Mukt Delhi. Thank you so much for patient here.
Thank you so much, ma'am. Excellent presentation of the initiative of Anemia Mukt Bharat, Anemia Mukt Delhi. I request our experts who are present in the meeting to please give their comments. We have Dr. Asmita Rathore, ma'am, with us.
Yeah, good afternoon. Am I audible?
Yes, ma'am, you're audible.
Yes, ma'am.
Yeah. Thank you, Dr. Manju. It was really an excellent presentation with all very, very practical tips. And I fully agree with Dr. Manju that I would like to start with the residents in our hospitals who see huge number of patients, and somehow in their mind that figure or a definition of anemia is set at a different level. 8 or 9 grams, they don't think something very serious. And I think that is the point where I would like to always emphasize and sort to resensitize them that keep the figure of 12 in your mind so that you get alert at an earlier level and act aggressively. I also have started an anemia room and now slowly making progress on counseling our patients on diet, and we have a dietitian sitting in the room. It was very interesting to know the study about the role of a knuckle pigmentation in detecting vitamin B12 deficiency. And I really agree that it's a very simple intervention and which can be used by all of us. Probably I at least was not so aware that such a simple sign is has such a good sensitivity to detect B12 deficiency. And B12 deficiency has a very peculiar presentation that it's not only anemia, but it's a sort of an picture where patient have a low platelet count and anemia which doesn't respond to your oral iron. So if we detect and intervene early, it can be a very useful thing. And I think, yes, it's a very, very important agenda and all of us have to work together. And as an AOGD, I think I will also like to have some sensitization of all our AOGD team also. And we will also work in that particular. Thank you so much, Manju. I think it's a long project, but under your leadership, you all will do well. Thank you so much.
I think,
Thank you,
Dr.
ma'am.
Manju, as I told you last time, I'm delighted. And I feel it is doable. And having worked both in the medical college and now in a private sector, I find, the private sector things will be probably more easy. And the only thing is we need to monitor ourselves, and I can definitely say we can take nursing home wise, institution wise, and everybody has to be this thing. And I'm really glad and delighted that at this age, I learned the other day that vitamin B12 deficiency can be so common, especially when your patient is not improving in spite of your best effort, that it is B12 which is creating a problem. And I think I'm very hopeful. I'm absolutely delighted about it. And I will see to it that At least 50% of the people who are private practitioners monitor their patients' hemoglobin right in the clinic before they leave the clinic. And they should have a set counseling as far as the nutrition is concerned, deworming is concerned. We used to, now hardly anybody is doing deworming, but I think, as you said, that after first trimester, deworming should be routine for even pregnant patients, especially if she is moderate anemia and less. So I think I'm excited. Dr. Sadhna?
Thank you. Dr. Sadhna, ma'am. Yes.
Thank you, Dr. Manjupuri. As we see to you as we can learn a lot from you. It is not only Delhi, it is a whole North India and whole nation. So first of all, the very, very important thing that was the system, a very root analysis that where we get lost and we don't get, because in our practice sometimes the patient gets hemoglobin and she comes after 1 month when her hemoglobin actually has to be repeated. So here is a big gap, and be it a small person, nursing home, or a be it institution, this is the point where we have to look at it. It is just a streamlining of system and very, very doable. So very, very important thing. And second thing about B12 deficiency. So actually what your research have already, what I have projected, actually in the developing world, it is now the WHO's statement also echoes your research, that it is not only iron deficiency anemia, actually it is multiple micronutrient deficiency, which is the cause of our failure to treat iron deficiency anemia. So I put the question to all the people, like getting serum ferritin B12 level and the folic acid estimation seems to be very far off. So like combining iron with the B12 and folic acid in a good dose, and of course what a hyperpigmentation, or what is a clinician observation, simple observation, that we supplement everybody with the multiple micronutrient, it will correct anemia. Not only correct anemia, it will correct the adverse obstetrical outcome, like by reducing homocystinuria. So likewise, if we do the research, I think we will really get the deficiency of iodine, we will really get the deficiency of B6 also. So that also lead to overall obstetrical outcome. So this is a thing like we have been like propagating now, that it is not the time of only iron and folic acid, but it is a multiple micronutrient deficiency. And the third is on our part, that the reading ABC of CBC, it has been our great, like all learning, like in all our educational program, learn the ABC to CBC, so we can identify megaloblastic anemia, we can identify the dimorphic anemia, and we can do a lot in the, not only in the first, but also the follow-up of the patient. So serum ferritin, yes, but B12 folic acid, I think we are not able to take, and the single injection. So it is a hyperpigmentation, it is neuropathy. There is nothing, very, very low cost treatment that we can do the injectable Vitcofol, and what we do to each other. So thank you very much for the wonderful insight, and as a presidential candidate and as a president NIGF, we will surely see that what your input, which your deep research and deep experience, we will carry forward your views and the action to the benefit of on the larger scale. And of course, Delhi is the capital, so Delhi always shows the way. So thank you very much for excellent presentation, and we have it is a really stimulating session for the many new ideas. Thank you very much.
Thank you, ma'am.
Dr. Sangeeta?
Thank you.
Thanks, Dr. Puri. It was really a very good talk, and I think whatever process deficiencies you have highlighted are the same in all the government organizations. So we have again to focus on those 5 whys and to focus on the problem where solving that problem can give us the maximum benefit. So that availability of the technician, availability of the equipment, and report receiving by the patient and reading by the doctors. These are very, very important points, and we all government doctors have to focus on the points highlighted by you. Secondly, while we are treating the other disorders, like other than pregnancy, like AUB, like most of the anemia cases which report in to our OPD are the cases who have taken over the counter abortion pill and have not been followed properly and have kept on bleeding, and they report to us. While they started, they were 12, 13, but now with 7, 8. So other problems which are there, we should highlight anemia problem along with treating those problems. May it be adolescent problem, may it be AUB, may it be a copper T follow-up, or may it be prescribing medical abortion pills. So simultaneously, we have to take care of hemoglobin level up to all those patients. And I think if we all join together, if we all focus together, we'll be very soon achieving our targets. Thanks.
Thank you, ma'am. Dr. Sona Bhatt, ma'am.
Excellent presentation, ma'am, and very nice data you presented. It's a very important point to note that deworming of all the patients is important. And secondly, don't ignore an HB of 10 grams per cent. I think this is a very good take-home message. Ma'am, we started with the routine B12 estimation and routine D3 estimation in our patients for past 2 years now. We have incorporated into our antenatal cards also. And the prevalence of B12 deficiency is quite high. And it's not easy for patients to tolerate B12 supplementation along with iron during pregnancy. So what I, as a personal practice, I do is that I always start the patients on pentoperazole with iron when I'm starting iron, so that they don't give up taking iron. And once they are settled for 15 days, then I withdraw pentoperazole. And second thing is for B12 supplementation, there is an inhaler available, which is in the name of Rhinocobal. It's 20 mcg, which is very helpful for the patient. So any patient who has a B12 level of less than 200, I give them this Rhinocobal inhaler, and it really helps in building up the B12 levels and brings the hemoglobin back to normal. And similarly, our neonatologists, they suggested us to introduce D3 estimation also. So we started with that also. In private practice, I think it is available. And a very important point Dr. Sangeeta has touched, I think we should somehow discourage the over-the-counter availability of MTP pills. We must find out some way so that these drugs are not available all over the counter, because there is nobody to follow these patients up. Thank you very much for the opportunity. It was a great learning experience.
Thank you.
Thank you, ma'am. Dr. Medalini Mani, ma'am.
Yeah, good evening, everyone. And at the outset, I must say thanks, Dr. everyone, for taking this initiative. And I'm very fortunate to be associated with Dr. Manjupuri, ma'am, from the beginning of this project. Simultaneously with ma'am, we started in June 21 for our patients' antenatal. And the results were amazing. And we took up a bottom approach because we knew that somehow we dispense a lot of medication to all our patients, but still they were anemic when they were coming to us. And our baseline data in the OPD was to the tune of 60% and IPD delivering patient 46%. So we started training, including our all sisters and guards also, when to take iron, how to take iron, so that most of the time patients talk to them when they are waiting, and these people become counselors. So we took this opportunity and taught them how to do a proper counseling regarding the diet and taking of medication, which was so important. And yes, we were adding multivitamin earlier. Now we have switched over to B complex and also asking for B complex injections with us. And over this 1 year's journey, rather 1.5 years, the results have been very heartening. And I'm proud to say that my booked indoor patient, now the anemia is only 7%, all mild, moderate, and severe combined. OPD, yes, we are still lagging behind because patients are coming from the field and we have to catch them. But from 60% plus, it has come down to about 32% at the moment. So we are very hopeful. And one initiative for Anemia Mukh Delhi, what we have started I started in my hospital training, catching hold of group C and D employees and cascading to them. And also, madam, we have requested our MS to test each and every family member of our employees from the beginning, start from home. घर से शुरू करेंगे तो हम बाहर जाके फील्ड में कैच करेंगे. तो हम अपने सारे हॉस्पिटल एम्प्लॉयज का कर रहे हैं area wise, so that we encourage them to bring their families over and get everyone HB tested. So we have about 1,500 odd employees. So we are starting from there ahead. Plus the patients, of course, the antenators and adolescent girls which come to us, and also any women coming to gynae OPD, we are testing, getting their complete profile done. So I think combined, we should be able to make at least Delhi anemia mukt very soon, and a step forward if everyone takes. Yeah.
Great. Wonderful.
Great, ma'am. We can have comments from Dr. Jyoti Bhaskar, ma'am.
I think everyone has put in so much that today I feel I need to do something. I need to start from today. Only one thing I felt, Madam Dr. Manju always talks about quality improvement. She being in a sector in the government, you talk about quality improvement in the OPD and at a much larger level. But I feel everything starts from us. So this whole steps of quality improvement, while you were talking, I was saying that if I change my practice, then at every level, whether am I interpreting the CBC properly, am I writing the PS for the patient, am I deworming the patient? If she comes to me at 28 to 34 weeks, hemoglobin less than 10, am I evaluating her, giving her parenteral iron? I think if each of these steps of quality improvement, I start doing it in myself, I'm definitely going to make a difference as far as my patients start. So instead of just advocating everyone do it, I think we need to start right now, at this particular moment, changing our own practice before we can do it. And second point that I really liked, and I have also started, is that between 28 to 34 weeks, despite taking iron treatment that she is generally on in private practice, if her hemoglobin is less, that's an opportunity, if it still turns out to be an iron deficiency, to give her a parenteral iron. And that makes a huge difference, because when she comes at 36 weeks, she's already more than 12. So instead of just pulling on thoda din aur le lo, double dose le lo, we do that. I think that's the right time to even think about giving her a parenteral iron. So thank you very much. In B12, yes, there are many combinations. I feel nowadays we have some of the calcium combinations, which are also giving 1,500 micrograms of B12. So if you really find them to be deficient, probably they all take calcium. Instead of adding an extra vitamin, probably we give them the ones which have the B12. So that can also tend to be working on. So thank you very much.
Yes, ma'am. Thank you, ma'am. Dr. Kiran Chhabra, ma'am.
Good afternoon, everyone. Thank you, Dr. Manju Puri, for your excellent deliberation. You are always a torch bearer, and as you have suggested and guided us how to fill the gaps in diagnosing anemia, in interpreting the PCV, that complete hemogram, we will definitely be doing much better in our practices. Though in my kind of practice, I'm already giving B12 in the first trimester to the patients along with folic acid. I get complete hemogram thrice in 9 months. And as Dr. Jyoti has suggested that give parenteral iron between 28 to 34 weeks, that also I'm trying to do, and giving my patients parenteral iron so that by the time they deliver, they have a good amount of hemoglobin in their bodies. So thank you very much for such an excellent deliberation and guiding us.
Thank you.
We have Dr. Mitra Saxena from Rewari. You want to make any comment, Dr. Sahab, in practice? How you can make this
very good afternoon, good evening to everybody. I think that everything has been said by whatever feelings were in my heart and brain have already been expressed. And really, as Dr. Jyoti and others have said, charity begins at home. So the good thing about attending today's session is that it is Dr. Manju Puri's motivation to make anemia-free Delhi. But I think we have understood a lot of simple facts about why our patients are not showing improvement. So like a good teacher makes things very simplified. So I would say that just looking at the CBC and understanding the relevance of all those indices, the MCV, I mean, little clues, and just a reminder by Dr. Manju Puri, I'm sure that at least all of us who are here will be doing correct justice to our patients. And moreover, if somebody sets their heart to do something, achieve something, we are all sure to reach that. So all the best to you, dear Manju, respected Dr. Sharda Jain. Ma'am, when you take up a project, you make sure that everybody, दुनिया का भला होना हो, हमारा खुद का भला जरूर होता है. So learning something correct, accurate has been a very fantastic blessing for me. Thank you so much, ma'am. Thank you, all of you.
I think anemia is dear to everybody's heart, and a shock coming to all of us in 2018 that instead of decreasing, we are definitely increasing. And there's something basically wrong with our quality management as far the patient care is concerned. And I think, the private practitioners, when they deliver patients, their target should be 12 gram%. And for the private people who are work in the government sector, they should see to it that the anemia incidence of less than 11 gram%. If Dr. Mani can do it 7%, I'm sure it will be possible if Dr. Manju Puri keeps, as far as the direction is concerned, as far the government sector is concerned. Manju Puri, I have worked in the same setting up, and I find, if you could motivate hemoglobin being done now for 3 or 4 times during pregnancy time is a great achievement as far as Lady Harding Medical College is concerned. And we see the absolutely contrast in the governments, in the private sector. Here to get a hemoglobin is not a problem. You have to be obsessed here. This lady should not go less than 11 gram% when she's going into labor. And when I say it can be 12, for the last 3 years, I have to see to it that hardly ever any single patient of ours hemoglobin is less than 12 gram%. It is all setting up your mind. And I'm sure in a private sector, we will see to it that things are definitely improved. And the only thing is, with your team and the government of Delhi team joining your hands, by the end of 2 years, you will find the incidence of even mild anemia will not be there in this in Delhi. So if the Delhi shows the roadmap, I'm sure everybody will be able to do this. But I'm indebted to you as for the B12 deficiency is concerned. If you just look at the knuckles, and your job is done.
That's
finally a student tells you that, madam, 75% will have B12 deficiency. एक छोटी सी चीज हमको इतने दिन लगे, इतने बार सफेद करके पता चला कि B12 की डेफिशिएंसी नकल्स में छुपी हुई है.
That's a good take-home point, ma'am. And I think instead of just routine iron folic acid supplementation, we should have a multi-micronutrient supplementation. Instead of a plain calcium tablet, we should have a calcium vitamin B12 tablets for routine antenatal supplementation.
I think this hunger as per the micronutrients are concerned, the country is highlighting it time and again, and we are for the last 2 years thinking about it. And I think over and above, Dr. Sadhana Gupta is on a mission to inform each and every gynecologist that micronutrient deficiency is very, very important, and the right time to give it to up is not only folic acid. The first trimester you should flood in these micronutrient deficiency, and without much of cost, I think, So these 2 new things have come up as for the pregnancy part is concerned. And I think each and every one of us should know the counseling part of it, and the senior gynecologist should spend about 5 to 10 minutes counseling them about the nutrition and relating it to the IQ of the child. If you relate it to the IQ of the child, I think things are going to really do wonders. Patient ही आपको कहेगी, मैडम आप मेरा हीमोग्लोबिन कराओ, मेरे बच्चे का IQ कितना है?
मैम बिल्कुल, ये हमारे यहाँ ऐसा ही हो गया. पेशेंट खुद से पूछे, मेरा हीमोग्लोबिन ड्यू था, मैम वो करवाओ, ऐसा वाला. उनको बताते हैं कि आपको याद दिलाना है, अब 4 हफ्ते में आएंगे, दोबारा होगा. So, the moment you link it to the IQ of the baby, they all want to get it done. And
the people who have worked with me don't know it. Our patients keep chasing us, doctor, aapne hemoglobin to karaya nahi aaj.
Ma'am, all middle-aged women should also screen for B12 deficiency.
Absolutely.
Vitamin D. The campaign by the government is also very smart one. Solid body and smart mind.
Smart mind.
I think this should go to all people for vitamin B12 supplementation and making our country anemia mukt. We can now move on to our next session, which is a panel discussion. And panel will be moderated by Dr. Aparna Sharma and Dr. Shilpi Nayan. The topic is important issues on anemia in women and adolescents. Dr. Aparna, we all know, she's professor in Department of Fetal Medicine Obsgynae at AIIMS, Delhi, and she's a chairperson of AOGD QI Committee 21-23. and a joint secretary of SFM in 22-23, and North Zone coordinator of Safe Motherhood Committee, FOXY 2020. Welcome, Dr. Aparna, and I welcome Dr. Shilpi Nayan. I unfortunately couldn't get the CV of Dr. Shilpi Nayan, so I think Dr. Aparna.
I'll introduce her. Shilpi is a professor from Department of Obs and Gynae, and she's actually active. He's basically the lead in the anemia project of Harding. She's the one who is actually keeping a tab on that. And a word about Aparna. So I owe all my quality improvement skills to Aparna. She's the one who introduced me to quality improvement in 2018. And we've been able to do a lot of projects after that, and we together. So welcome, Aparna and Shilpi. Please go ahead with your panel. Yeah. Thank you.
Great. Thank you.
A very good afternoon to all of you, and thank you, ma'am, for having me here today, and thank you, Manjupuri, ma'am, for leading the QI journey as always and encouraging us all to do more and more. We are here together, Shilpi and me, and although ma'am has covered this topic so brilliantly, I think there is hardly anything that we can add. But I think we do have a brilliant panel, with us today. Dr. Swati Sinha from Rainbow Hospital, Dr. Anuradha Singh from LHMC, Dr. Anita Agarwal from East Delhi, Dr. Ritu Sharma from JIMS Noida, Dr. Harvinder from DDU Hospital, and Dr. Vinita Gupta from Baba Saheb Ambedkar Hospital. So we're going to discuss a few aspects of anemia. Essentially, they would be some of the topics that we've already discussed, and we would take it one by one. Before I begin, just a word about the micronutrient discussion that has been happening. Although we would love to have the micronutrients on board, unfortunately, the evidence on consolidated micronutrient supplements is still not available. So I think that is something that we are still going to see. Iron is good, B12 is good, folate is good on its own, but a consolidated micronutrient deficiency is still not evidence-based. So I thought I'll just put it out there before we actually take it up, across the table. So I thought I should just mention this before we go on. So I would first invite Shilpi to take the first case on adolescent anemia.
Yeah, thank you, Dr. Aparna. Without wasting any time, I would just highlight on this map, which is depicting the prevalence of anemia in Indian adolescents, where the light pink is a lighter anemia and the dark pink is a severe anemia. So we can see that most of these states are having anemic patients and anemic adolescents. So I'll start with my first case. 15-year-old Tina doesn't want to play with her friends. She feels tired all the time and doesn't eat well. She has an urge to eat clay chalk at times, and she looks pale. So her mother has taken her to a doctor at Village PHC. And so I would like to ask you, Dr. Swati, how would you prefer to evaluate for anemia? Symptoms are important, or you would go for specific signs and start treatment, or you would first like to have some tests?
Thank you, Dr. Shilpi. At the outset, I would like to wish a very good afternoon and good evening to all the esteemed seniors who are present here and my colleagues. And it's a very interesting topic, and we've had a very great session till now. So regarding this adolescent girl who has visited the PHC, it is very much, we all know that anemia is something that affects not just the physical well-being, but also the emotional and the general well-being of any person. Sorry, can we go? The signs and symptoms are visible that the person is not feeling up to the mark. She's lethargic and exhausted, does not feel like participating in her day-to-day activities. And symptoms in terms of pallor is very visible. Tests, I think in a PHC, the point of care test would be a spot hemoglobin, which is done by looking at the color. It's a non-invasive test. However, if you were to ask, CBC is a gold standard test. Am I audible? Sorry.
Yes.
Sorry. So a CBC would be a gold standard, but I understand that it is not done as the first level in many centers. So a spot hemoglobin would be the first line test in a PHC.
Absolutely. As Dr. Swati said, So at a facility which is at a PHC level, we get spot hemoglobin done, which leads to a faster management and faster treatment of the patient. And meanwhile, we can get a detailed evaluation. So Dr. Vinita, would you like to tell us how would you classify anemia? How would you go ahead with the diagnosis of severity of anemia? Do we have Dr. Vinita here?
Dr. Vinita, you there?
Sorry. Okay. Hi. Hi, Shilpi. Hi, Dr. Aparna. Thank you for having me here, as this is a case of adolescent girl. So according to WHO, the anemia in the adolescent girl is defined as any hemoglobin less than 12 gram%. And as to classify the anemia in adolescent girl, so it is mild, moderate, severe, as the same we have in the pregnant woman. So hemoglobin between 11 to 11.9 is mild anemia. Hemoglobin between 8 to 10.9 is moderate, and between less than 8 gram is severe anemia. And it is important to highlight here that as a gynecologist, we are used to seeing the pregnant woman where the anemia is less than 11 gram%. And as Dr. Manjupuri has already said, we are happy with hemoglobin between 8 to 10, very happy. So especially in adolescent girls, any hemoglobin less than 18 or 8 is almost severe anemia. So we should target of having a hemoglobin of at least 12 in adolescent girl.
Yeah.
It affects their cognitive and the motor development and their school performance also. So it is very important to know what is the anemia in an adolescent girl.
Absolutely. So we can go ahead with the peripheral smear examination as well as the ferritin estimation to tell us about the type of anemia and guide us through the treatment. The various ferritin levels are there to guide us that whether it is an iron deficiency anemia or not. And according to that, the symptoms are also accelerating. So symptoms will help us to know whether she's improving or not. And the ferritin can tell us about the severity. So Dr. Ritu, can you tell us what are the probable causes of anemia in adolescents?
Yeah. Hello. Am I audible?
Yes, yes.
Yeah. Hello. Thank you, Dr. Manjupuri ma'am, Dr. Aparna Sharma ma'am, and Dr. Shilpi for including me in the panel. The probable causes of anemia in adolescents, most common cause is the nutritional itself. They are having the nutritional deficiencies. And second is that in case of the females, if we take the females, then there can be the menstrual problems as well. And also the socioeconomic factors like socioeconomic factors, the dietary factors, they are, I think, the main causes leading to this. Then whether the health facilities which are available, whether they are approachable or not. And I think main reason is the socioeconomic, dietary, and the cultural issues related to the gender discrimination also. And I think these are all the factors.
Absolutely. So keeping all these factors in mind, this is important to, since as we saw in the previous talk, that the analysis of what is the cause is a good directive which can tell us how to treat it. So Dr. Harvinder, can you advise regarding how will you treat her now? Her hemoglobin has come as 8.2 and she's 16-year girl. So
Yeah.
how are we going to go ahead?
Good evening, everyone, and thank you for providing me the opportunity. As this is an adolescent girl with hemoglobin 8.2, so she falls under the category of moderate anemia. So I would like to give a therapeutic dose of iron and folic acid. I would prescribe her 2 doses of blue tablet, which is provided free by the Government of India, each containing 60 milligram of elemental iron along with the 500 microgram of folic acid. I will tell her to take twice a day, at least for 3 months.
Yeah, as we can see in this chart, she has to take for 3 months, and if there's no improvement, she should be referred for a detailed evaluation. And if there is an improvement, then definitely she should continue with a prophylactic treatment. So Dr.
Anita.
Yeah, it's Dr. Anita. So tell me, what is your opinion on deworming? We've already had enough, but a focus on deworming in adolescents. Can you please elaborate?
Good afternoon, everyone, and thanks for giving me this opportunity to be in this panel. We all know that deworming is very important in our country, developing country like us, because we have high prevalence of intestinal elephantiasis. And we also know that it has an inverse relationship with the hemoglobin level. So it has been seen that when we deworm a patient or a girl of adolescent age, their hemoglobin level improves. And various randomized controlled trials have also shown that. So it's very important. And it has, since it has been recognized by our government also, so school deworming programs they have initiated, and they have seen that there is much improvement in hemoglobin level of the children. So it's very important to deworm, and as well as in pregnant ladies also, we recommend that they should be provided with at least one dose of albendazole of 400 mg during second or third trimester. Besides this.
Thank you, Dr. Neeta. So after deworming and giving iron supplementation to this patient, I think there is, as we saw in the causes, what are the causes of anemia in adolescents? So Dr. Anuradha, can you tell us what other advice will you give to this girl?
Hello, everyone. I think the very important advice which you give to these adolescents or any reproductive age group female which is coming to us, that the iron tablets are specifically to be taken 1 to 2 hours after their major meals. And the calcium is not to be taken together, especially in case of pregnant women. And they can be taken with vitamin C supplements, like normal routine lemon water that can be taken. And of course, we are definitely addicted to caffeine intake or tea intake, especially in the adolescent age group. So after the caffeine or the tea intake, it has to be taken after 1 to 2 hours. Apart from that, the dietary advice has to go hand in hand with the prescription, because that is the most important thing they focus on, like they're being pregnant or they are adolescents. So dietary advice is the most important. Green leafy vegetables, variety of this, which is I think seen on the screen also, and the nuts and the pulses and the jaggery. I think jaggery is one thing which is a most important source of iron and should be advised regularly in diet of adolescent anemia.
Yeah, so looking at nutrients and vitamin C rich food. Another important thing is hygiene. So they have to maintain hygiene, and definitely the prevention of malaria. And in case they are found anemic, they should be identified early and referred.
Yes, that increases the incidence of actually these helminthic infections if they are not maintaining a good food and personal hygiene also. So I think that is the most important thing also highlighted well.
Yes. So after we have seen that there is an intergenerational cycle of anemia. If the adolescent is anemic, they become pregnant, and they become pregnant with anemia, and they give birth to low birth weight babies with low iron reserves. Now we have corrected this girl. She's beautiful and she is going to school now. So I would hand over the panel discussion to Dr. Aparna to moderate the next case.
Yeah, so we now move on to the next case, which is now we have a lady who's pregnant. So she's a 21-year-old and she's primary gravida who's come to the OPD at 4 months, and she's currently like 16 weeks pregnant, and she was advised her routine investigations. So her hemoglobin comes out to be 9 grams. So my question to Dr. Ritu. So my question to Dr. Ritu would be that what will you do next? Do you go for further investigations, like, give all the battery of investigations, or would you like to go for a trial of therapeutic iron? Because, we are such rich in iron deficiency anemia that you would like to treat her first and then go for investigations. What would you do in your practice?
Yeah. Ideally, the patient should be investigated, but considering the high prevalence of iron deficiency anemia in our setting, and also due to the resource limitations or the resource constraints, I think the trial of iron is recommended by WHO as well. And I would prefer to go for the trial of oral iron therapy. Since she is in early gestational age and she is having moderate anemia, I would like to go first with the oral iron, that is 2 tablets per day. containing that elemental iron 60 milligram and folic acid 500 microgram, and that has to be continued. And then I have to follow up the patient. I think first follow-up should be after 1 month with the repeat HB, and if that is improving, then I can continue with the same and till the HB is normal, and thereafter the maintenance dose may be given for the next 3 months. If it is not improving, then I have to reevaluate the patient. And so this oral iron will serve the dual purpose. It will be therapeutic trial also, and it will be diagnostic also.
Right, right. So thank you, Dr. Ritu. So Dr. Swati, I would like to take this up further with you. So now we have a mixed kind of an audience and mixed kind of a practice, and we have varied population. So yes, ideal is that we investigate, but yes, a diagnostic or a therapeutic trial of iron is a recommendation which has been given by various organizations. So when would you end this therapeutic trial, and what would be the next step in the management? So it's important to mention here that this is an approach in resource limited settings. So just to complete this point here, Dr. Swati.
So yes, in a low resource setting, we would like to do a repeat hemoglobin after giving her iron for about at least a month. But in a resource rich setting, we may repeat it after 15 days to see if we are getting a response to oral iron. If not, then maybe would like to investigate for other causes of anemia and check for iron stores. If found to be deficient, we can consider giving her parenteral iron.
Yes, so I think that is what. So generally we say that after 1 month of oral iron, and I think this is what we want to say again and again, that once we have given her iron, let's not forget it. We have to repeat a hemoglobin. We have to see whether she's responding, and that's the crux of treatment of anemia, because once we are starting the treatment, we have to make sure that she has responded. So coming to the next point, Dr. Anita, we would like to know that, one cutoff, something that we have to fix it in our minds, that, okay, this is not looking good, this is abnormal, this is normal. So what are the certain things that you would like to, keep us, that we should keep in mind? What are the stages of IDA? What is important in iron deficiency anemia, and what are the normal values?
Yeah, we have, there are 3 stages of iron deficiency anemia. First of all, there is iron depletion. Stores of iron, they get depleted, maybe because of increased demand, less intake, or increased growth demand, bleeding, etc. So this iron depletion of store is not shown in hemoglobin or indices. So they remain normal when this first stage occurs in iron deficiency anemia. Then comes when it is not complete replenited, then comes iron deficiency erythropoiesis. Like in deficient state, hemoglobin production has started. So in this stage, we can find there will be low iron, decreased ferritin, increased iron binding capacity, but still there is no anemia. But in our smear, we can find RBC slightly microcytic still. So already 2 stages of anemia has progressed. But unless we do these things, we won't be able to find out, because hemoglobin till now is normal. Then 3rd stage, still hemoglobin iron supplementation is not done. Full-fledged picture of iron deficiency anemia happens, which results in low hemoglobin, ferritin level, and serum iron. Decreased oxygen carrying delivery to the tissue, and iron binding capacity also increases. All the laboratory tests will be abnormal. So these are the 3 stages of iron deficiency anemia. So when anemia happens, all these things, all the parameters, they decrease. MCV, HCV, RDW, everything get
Right. Thank you, Dr. Anita. So, and why this is important is that because, yes, please.
It's okay. Normal indices, the normal values were like MCH. Various indices are MCV, mean corpuscle volume. It's the volume of the red cells, which is like 82.5 to 98 plus minus. Mean corpuscle hemoglobin concentration is the concentration of hemoglobin in inner red cells, which is around 32 to this is 17 to 32%. And MCHC is the percentage of hemoglobin, which is 32 to 36%. And
Right,
similarly,
right. I think these are the two, yeah. So these two values are something that we should remember. So like we said that, as clinicians, we are not very comfortable reading these numbers. And that's why we are waiting on this slide and, really emphasizing that we have to look at the MCV being between 82 to 98, and if this is less than 80 or more than 100, we know that it is microcytosis or macrocytes. So this is something which becomes important to make a diagnosis. And if the RDW is increased, that means that the anisocytosis is there, more than 13.5, then the anisocytosis is there. So why this is important? Again, the various stages of iron deficiency become important are because this is a slow process which has been happening, and hence prophylaxis also is very important. Iron prophylaxis is important because iron deficiency anemia develops slowly over a period of time. So Dr. Harvinder, just a few more things about trying to understand the diagnosis of anemia and why this becomes very important. So regarding microcytosis, because when we are diagnosing anemia, a peripheral smear becomes very important. So a few things about peripheral smear also which we need to understand as clinicians when we read the smear. So can you tell us about the peripheral smear and the microcytosis of anemia? Dr. Harvinder?
Yeah. Can you hear me? Yeah.
Yes, now.
Peripheral smear is an inexpensive test, but it is a powerful test. It provides so many information. It tells us about the size, shape, and number of the RBC, platelets, as well as WBC. It tells us about whether it is a microcytic anemia or a macrocytic anemia to make the diagnosis clear. And it also tells us about the hyperchromia. And it also tells us about the various inclusion bodies which are present in the cells, RBC, parasites. It tells us about the various type of this leukemias. It provides many information we can diagnose on the peripheral smear. Most importantly, the type of anemia on the peripheral smear. If it is a microcytic anemia, then we can have it may be because of the iron deficiency anemia, anemia of chronic disease, then sideroblastic anemia or thalassemia. So to make the diagnosis clear, it is very important to have a peripheral smear.
Right. So I think peripheral smear is one of the, like Dr. Harvinder said, one of the most powerful investigations and one of the first investigations. But when we have microcytosis, we also have to think about thalassemia. And that is something, especially in our part of the country. And that's one of the important reasons why they may not be responding to our treatment. So we have to keep that in mind, that 40% of pregnant women with actually absence of microcytosis does not eliminate the possibility of iron deficiency anemia, because what madam has also been telling is that dimorphic anemia contributes to the absence of microcytosis. So the presence of a concomitant nutritional deficiency of B12 and folate may lead to actually the absence of microcytosis. So we have to rely on a peripheral smear, at the same time do a complete analysis. So now, additionally, now that we are so resource rich, now we're moving from a resource poor to a resource rich setting, we do have the options of additional investigations. Now, do you have a low hemoglobin? So, Dr. Anuradha, I want to understand, when would you want the ferritin or additional iron indications? What is the role? When would you want to do it?
See, ferritin is usually indicated in our setup. What we are doing is when we want to diagnose iron deficiency anemia, because this is the first component or because this is a storage protein basically, which is circulating free in the blood and which is carrying that heme component. So it is the most important thing and the first thing to get affected. So when we want to diagnose iron deficiency anemia, or we want to give a parenteral iron, because the side effects associated with parenteral iron sometimes are life-threatening. So a ferritin is a must before we start basically the parenteral iron therapy. And if we want to rule out the other causes of anemia, so ferritin is the most important thing which is to be done in our patients. And when your patient is not responding, see, you have given an oral iron, suppose you are sitting in a health center and you have given an oral iron and on the basis of a spot hemoglobin test. And when your patient is not improving, maybe some other causes, like everyone is saying a micronutrient deficiency or something like that, then we need to do this ferritin test to see whether your patient is responding, number one, and to rule out the other causes.
So thank you, Dr. Anuradha. You told it very clearly that, if we are suspecting or we want to start a parenteral iron therapy, or the patient is not responding to your oral iron, so that becomes like a next level testing. So it's like the next step. So you have microcytosis, you have a peripheral smear, you have the MCV. So you have a diagnosis of iron deficiency. You start them on iron. Not responding, you go to the next level, which is ferritin. But
and ferritin is, the ferritin is actually maybe raised in cases of iron deficiency in certain inflammations or certain hepatic
So that's
disorders.
my next question. That's my next question. So this is where I'm coming in, that, okay, so you say that you are doing ferritin and ferritin is raised, but you are expecting a normal ferritin, right? We are expecting a low ferritin because you are supposed to be having an iron deficient state. So ferritin should be low, but the ferritin is not low. So what are you going to do? Because in the setting of an inflammation, it is falsely elevated. So what are you going to do? So that is my next question to Dr. Ritu, that what is to be done if the serum ferritin levels are indeterminate? Because you are coming from a place where you think that your diagnosis is definitely iron deficiency. You think that, okay, the picture is microcytosis and you have a low MCV, but when you do the ferritin, it is in the level of 31 to 99. So if you have a ferritin which is less than 15, you think it is iron deficiency. More than 100, you rule out that it is not iron deficiency. But when you have an intermediate ferritin, then how do you go about it?
Yeah, as far as this case is concerned, she is a diagnosed case of anemia with microcytosis and with this ferritin, which is almost in the normal range. Then I think I have to rule out other causes of microcytosis, like thalassemia. I have to rule out, and for that I can go for the HB electrophoresis, and I can go for a simple test, that is the Manser index. I can calculate that also, and I have to rule out the other causes like the chronic inflammations and other malignancies, which may in these cases also the ferritin level may be normal in that range which you have mentioned. I have to rule out those also.
Right. So here, as Dr. Ritu is saying, so one point is that you probably think of thalassemia because the ferritin is slightly raised and not very high. So a thalassemia minor may not have a very high iron load also. But what I wanted to stress here also is that this is the window where you would want to do the other tests like serum transferrin saturation, TIBC, serum iron. So the entire gamut of your iron studies, this is the place where the role comes. That when you have a confusing serum ferritin in a picture where you are thinking that it is iron deficiency anemia, this is where you want to do the entire gamut of iron studies and not blindly suggest iron studies to everybody. So there is a logic to doing investigations behind iron deficiency anemia in your patients who are having iron deficiency, patients of anemia with iron deficiency. So this is the concept of doing when you have indeterminate ferritin and you suggest further testing. So as we see, if you are having a low ferritin, so you can actually indeterminate ferritin, you can do TIBC and other serum iron and percentage saturation to understand whether it is iron deficiency or not, and then you can go on with your treatment. So Dr. Anita, so when is the other situation when you would look for, okay, now this is not iron deficiency, I want to go for other causes. This does not look like iron deficiency. So what are the other situations in which you would go for other causes?
Yeah, if patient does not respond to iron supplementation within 2 weeks, then you start your investigation, detailed history, clinical examination to rule out other causes for anemia. Could be malabsorption or malignancy, thalassemia, childhood bleeding disorders, or various nutritional deficiencies. So these are the tests which you start performing once your response is not there within 2 weeks, because hemoglobin level starts increasing after 2 weeks.
Right. So you're saying
And
that once patient is not responding, you need to investigate further and look for it. So essentially, if there is macrocytosis, you look for B12 deficiencies. If there is extreme microcytosis, you look for thalassemia. If there is abnormal WBC count, then of course you look for leukemias or some other morphologies. So all of them, then they become the next line testing, and then you proceed further. So, Dr. Harvinder, I think we covered the diet a bit previously on the adolescent anemia, but of course, as Dr. Anuradha already mentioned, all of them become very, very important. Would you like to take something that has not been mentioned by Dr. Anuradha? You think that something has been missed? Pregnancy, diet, anemia, any point that you want to add here?
It is very important that cooking in the iron utensils is also very important to increase the iron supplement. And rest of all is covered by Dr. Anuradha, green leafy vegetable. And if the patient is non-vegetarian, the absorption from the heme part is more. So we can advise her, if she is a non-vegetarian, increase the dose of egg yolk, livers or meat. And I think rest all is covered. जैसे हम initially बोलते थे गुड़, अंकुरित दाल, चना, it should be a routine statement to all the patients, antenatal patient coming to the OPD, increase the good dal, chana with their diet.
Right. So I think the material is a lot. I think all of us will have a lot of material available, but the important thing is to talk to them and take time out of our busy schedules to talk to them about dietary modifications regarding anemia, dietary specifications, and being careful about diet regarding iron.
Yeah,
so,
can I add something? Yeah, we need to actually talk to them about their dietary habits also. What is the routine things which are available in their households? What are they routinely eating? So in that scenario, looking also the economic circumstances of the patient, I think we can advise the diet accordingly. That is the most important thing.
Absolutely. I think we need to be contextual about it and not advise something that they cannot take. Now the next thing is for prophylaxis. Dr. Anuradha, can you just continue on what is your practice and how would you give oral iron for prophylaxis? Like we saw that it is a continuous process and it progresses. So how would you go about it?
See, in pregnancy, because she is a 16 weeks pregnant lady, so oral iron prophylaxis preferably has to start from 16 weeks onwards. It is basically 2 tablets daily, which is to be taken, each containing 60 milligram of elemental iron and 500 microgram of folic acid, which is essential. Minimum of 180 days is required, and that has to continue postpartum. So that is the most essential thing which is important. It just needs to, and it is in our setup, it has to be a continuous therapy. We have to stress upon that because there are a lot of factors which hinders the improvement in hemoglobin. So it has to be a continuous therapy in my setup.
But have you ever considered or given an intermittent therapy as has been recommended?
Yes. Those who do not have a very low hemoglobin, or those who actually have a 12-gram hemoglobin to start, I can advise, if they are not tolerating, we can have something like an alternate day therapy or twice a week therapy if they are not tolerating well. But that basically in cases of places where the prevalence of anemia is not very high, in our setup, I would definitely advise them daily and check for the compliance in the next visit, which is important, whether they're actually taking it or not.
Yes, but I think we should keep this in mind for people who are not accepting and who have a basic good hemoglobin level, that an intermittent iron therapy is also an option. So now coming to this case who had, so if the patient has mild anemia, right? So mild iron deficiency anemia. So Dr. Ritu, how would you treat the mild anemia?
I think, ma'am, it has already been covered in the previous case also. I will start with the oral iron therapy, and the 2 tablets of oral iron will be given per day. And the patient will be followed for the improvement via doing the HbC hemoglobin levels, and after 1 month. And if that is raising, then I have to continue with and the symptoms they are improving, I have to continue with the same treatment till the HbA levels they reach the normal levels, and then I have to give the maintenance dose, continue with the maintenance dose, 1 tablet OD for the next 3 months, and I have to continue it in the postpartum period as well. But if she is not responding, obviously, then I have to reevaluate. And obviously, as previously been discussed, I have to give the dietary advice and deworming
in this patient
Right,
also.
right. So thank you, Dr. Ritu. I think most importantly, we need to follow it up with a repeat hemoglobin after 1 month to see the response. I think that is what we forget to do. And we have to see whether she's responding or not. Now, this is one question that is always comes to our mind, whether we can give oral iron in the first trimester. Dr. Swati.
So, as a general practice, we usually do not give oral iron in the first trimester because the safety is not proven. And there, in fact, as per some murine models, it is also said that high iron levels are even toxic to embryogenesis. So, as a routine, we do not like to give oral iron.
But if the patient is anemic, then what would you do? If the patient is anemic in the first trimester, what would you do?
Then maybe we can just, after 9 weeks, maybe we can start with oral iron.
Yeah, so actually, first of all, we don't probably need iron in the first trimester because it's not really the requirement is not increased. So it is probably prudent to delay. Practice is mostly avoided due to gastric irritation.
Yeah.
But practically it can be given because most of the guidelines do endorse it because the evidence is not very high on its toxicity. So if it is required, we can give it, generally avoided because of the GI side effects.
Right.
So that's where we stand with the evidence on the. So what are the side effects of oral iron? I think this is the toughest question, and this is for you, Dr. Vinita. That I think this is one of the reasons
Dr.
why we are
Aparna,
not
the
able
side
to.
effects of oral iron are not very serious. They are mainly the GI side effects in the form of nausea or upset in the form of
But Dr.
moderate
Vinita, you
diarrhea.
cannot say they are not serious. I think this is one of the biggest reasons why we are
they
still
are the
struggling
most
with anemia.
disturbing side effects actually because oral side effects in the form of alternating diarrhea or constipation, pain, abdomen are really very disturbing to a day-to-day life of a patient. But they can be tackled by good counseling and advice to take the oral iron after at least 1 hour after the meal. That is the one very good strategy. But if at all the symptoms are still not controlled, then the other options are that they think is to take the iron tablet at the bedtime, because at that time the majority of the symptoms the patient falls asleep and then it is not disturbing. The other thing is that it can, if still they are not controlled, they can be advised regarding the stoppage of the iron therapy for some time and then restarting the therapy with a small dose after 3 to 5 days or 5 to 7 days. And if still not controlled, then it is better to change the salt of the iron, oral iron therapy. So they are the 4 main modalities of the treatment of the side effects.
Right. So like you said, intermittent you can do, content you can decrease, or changing to an alternative preparation, taking with meals or maybe taking at bedtime.
Majority of the time, the counseling is the one which helps, to overcome the side effects. You do the good counseling, you tell the benefits of taking it rather than avoiding the side effects. They will, start tolerating the oral iron. That is what I think.
Can I make a comment? Actually, in my setup, I have seen that majority of the patients won't even tell you the side effects. They just have a low hemoglobin, and on repeated questioning, they will say, okay, mere ko to thoda sa intolerance hai ya kuch hai. It is that way. Then you need to ask about it, because majority of the patients will not tell.
Yeah.
That's very true. Shilpi, you would like to take this case up?
Yeah, so we come to the next case. She's a third gravida para to living to a rural woman with twin pregnancy. She comes at an advanced gestation with a hemoglobin of 8.5. So she's taken oral iron, which is given to her. And on investigations, she's found microcytic hypochromic iron deficiency anemia. So now how do we deal with this patient? Dr. Anita?
Yeah. Since she is in her last trimester and hemoglobin is, she is having moderate anemia. So next is we can go ahead with the parenteral iron. So parenteral iron can be given either intramuscularly or intravenous. Earlier we used to, in our setting, we used to give intramuscular iron, but it has lots of side effects and sensitivity reactions. So nowadays we give IV iron. So just a word about intramuscular iron, and before giving parenteral iron, we must reconfirm the iron deficiency by checking so that she should not be thalassaemic. it should be a good facility where one can monitor the patient, and we should have ready drugs for in case of any anaphylactic reactions. So and someone to supervise the iron infusion in whatever way. So the side effects of intramuscular iron is repeated injections. They can cause itching, discoloration, arthralgia, and joint pains, which is very, very common in such patients, lymphadenopathy, etc. So this is the side effects. And one more important thing is that we should stop oral iron before proceeding parenteral iron, minimum at least 24 hours, so that to avoid the toxic reaction. And IV iron sucrose is very good, and we give right and left because it has minimal side effects and minimal hypersensitivity reactions. And within 15-20 minutes, it can be given in any setting when some doctor is available, and it is not time consuming, and it causes rapid rise in hemoglobin level. And as well as stores of the iron stores are very much improved by the time she is going to deliver.
Absolutely. So, but we also have to keep the number of visits in our mind, whether the patient is staying nearby and she can come over, because with the COVID making us stagger our admissions, we have to think about whether we have to give iron sucrose or carboxymaltose. So, Dr. Harvinder, what parenteral iron would you prefer in your hospital, and whether they are available?
I would like to give, we have two parenteral preparations available, iron sucrose and ferric carboxymaltose. And we are using both now. Recently, we have in the government setup, the FCM is also available. And I would like to give FCM to this patient because of the better compliance. As the single dose is required, we can give 1,000 milligram in a single dose to be dissolved in 200 ml of normal saline and infused over 15 to 20 minutes. And a maximum of 1,000 milligram is given in a single sitting in a week. Then if another dose is required, we can give in a second week. But in case of iron sucrose, maximum dose of can be given is 600 milligram in a week. 200 milligram of dissolved in 200 ml of normal saline is given in a day. Alternate day, we can give 3 doses. A maximum of 600 milligram can be given. I have recently done a thesis with FCM on a patient of 100 patient, which I have seen the rise of hemoglobin is better with FCM along with the better compliance. And the side effects are almost same in both the preparations. So I would like to go with FCM.
Yeah, we recently had a study from AIMS also by Dr. JB Sharma. I don't remember exactly, but that was a controlled trial and it also proved the same. So we are also following the same, but iron sucrose is definitely more in practice, and the dose can be calculated by the Ganzini's formula. So Dr. Anuradha, can you tell us what is the management after the total dose of iron is being administered?
Yeah, for oral iron, basically, after the total dose is over and we feel that the hemoglobin has come up to the desired level, we need to give it additionally for 3 to 4 months to build up the stores. But that is not the case of parenteral iron. It is said that in parenteral iron, if your desired hemoglobin is somewhere around 12 gram%, then you need not give the further dosing. If your hemoglobin stays at that level, you did not, because that builds up the stores also. So that is the additional advantage with parenteral iron.
So after the parenteral iron, we come to the case number 3, Dr. Aparna ma'am.
Yeah. So here now we come to this case in which this is the report of the patient in which the hemoglobin is 8.5. She is now at 24 weeks of pregnancy. Now we see here that she has dimorphic anemia, where she has anisocytosis with a dimorphic anemia. So we continued her investigations and we saw that she, although with a low serum iron, and she has TIBC which is increased, transferrin saturation which is decreased, serum B12 is also decreased, and the folate levels. So essentially we have a situation where we have both nutritional deficiency of iron and folate, iron and B12. So this is iron deficiency with megaloblastic anemia. So before we go on to the megaloblastic part, I would just like to ask from Dr. Vinita. Now, this is a mid-gestation moderate iron deficiency anemia.
Yeah.
So what will you do for the iron deficiency anemia? This is mid-gestation with iron deficiency anemia, moderate.
Yeah. Dr. Aparna, it is mid-gestation iron deficiency anemia. So I would like to go for the oral iron therapy, starting with 60 milligram of elemental iron twice a day, along with the folic acid, 5 milligram, because it is a megaloblastic anemia. So dimorphic. So we have to increase the dose of folic acid. So till the anemia is corrected, and I would like to do the repeat investigation of the hemoglobin after 1 month, along with vitamin B12, that is 1000 micrograms single dose IM, followed by 1000 milligram daily till the anemia is corrected. So that is how we go.
Right. So I think Dr. Ritu, can you also add on to it? Like, what would you like to do? So I think the dosing, I think ma'am said that they have tried a single dose of B12, but what we traditionally talk about is, Dr. Ritu, would you like to also talk about the dosing of B12?
Yeah, ma'am, B12 parenteral dose, we usually we are giving it as 1000 microgram per day for 7 days. Then it is followed by weekly. Then it is followed monthly thereafter. This is the usual practice we are doing. We are following, and also we can give it on alternate day basis also. That is thrice a week. Dose can also be followed. Yeah.
Right.
Dr. Aparna, I think 1000 micrograms IM single shot followed by 1000 micrograms per day orally is as good.
There are varied protocols for that. Like here it is prescribed once per week till it is corrected, then per month. And we are also giving orally, in fact. So we give it orally once per day. So I think those protocols are also there. So there are multiple things. And like ma'am said that they have tried giving it a single shot of 1000 microgram. So I think there are various protocols which are available. But the idea is that this is a very crucial element of deficiency, which can cause refractory iron deficiency anemia. In fact, worsening iron deficiency anemia despite the iron supplementation, and needs to be kept in mind at all times. And what about folate deficiency? Dr. Ritu, you can just cut. So, yeah.
Yeah, ma'am, as far as folate deficiency is concerned, the therapeutic dose varies from 1 to 5 milligram. Usually we are giving it 5 milligram per day oral dose. And it is to be continued postpartum. In the postpartum period also, it is to be continued for 4 weeks postpartum. And along with this folate deficiency, we can add the supplement. We can supplement it with the B12 prescription also. And as you were already previously discussing regarding the oral and the parenteral therapy of B12, I would like to emphasize that the recent that Cochrane review has failed to demonstrate the equivalence of that this oral therapy as compared to the intramuscular, that is the parenteral therapy. But maybe it may be due to the lack of the good quality these studies. And but the advantages of this injectable therapy, I think they are more. That is, there are the dosing is not frequent, and also this improved compliance is there. And there are no GI side effects also. Yeah.
Right. So I think that is about. So Dr. Harvinder, how do you assess the response to therapy? And I think it is common for all of the anemias, whether it is iron deficiency or whether it is B12 and folate deficiency. How to assess the response?
The most important, the symptom it relieved is sense of well-being. The patient always says after 5 days कि मुझे अच्छा लगने लगा है. The sense of well-being is the most important symptom to get relieved. After that, there is a rise in the retic count. We can see the rise in retic count after 6 to 7 days. The maximum rise can be seen up to 4%. Then after that, we can see the rise in the hemoglobin. Hemoglobin levels start rising after 2 to 3 weeks by the 1 gram per deciliter per week. And then after then the stores get replenished. We see the improvement in the MCV, MCH, and the ferritin levels.
Right. So I think very important that we keep monitoring the patient for the response and to see whether our patient is responding or not, and take corrective measures in time. So now this is the last case that we wanted to talk about, and the importance of looking at the complete picture of CBC to interpret it nicely. So here we have a picture where we have a hemogram, which is 7 gram %, MCV, which is 58, MCH, which is 16.7, RBC count is 4.18. Now, in our routine practice, how many times do we actually look at the RBC count? It's a very easy thing here. So if you look at this picture here, the RBC count is very well mentioned here in all of our CBCs. And here it is shown as 4.18, if I can be very clear. Now, Menser index is something which we can easily calculate by dividing the MCV divided by the RBC count. So 58 divided by 4.8. So something to really, a simple calculation which we can do in our day-to-day life. So in this particular case, on further investigations, we found that the serum ferritin was 3.6. So she also had iron deficiency anemia. Her TIBC was 442. Her husband HPLC was normal. So I would just like Dr. Swati to discuss what is the diagnosis here, and is this very common in our situation?
As we have seen, I think the HPLC for the woman has been done, and that shows thalassemia minor. So this looks like a case of thalassemia minor with iron deficiency anemia, which is also a very common condition. People are not aware of their thalassemia status. And the HbA2 is usually more than 3.5, that is diagnostic of thalassemia minor. So that is and many times it is associated along with iron deficiency. So by giving oral iron supplementation, the hemoglobin improves considerably compared to what it is at the moment. It can reach to a maximum of 9.5, 10, 10.5. That is what we are looking at in a thalassemic woman.
Right. So this is why we have highlighted this report here, is that this is a very simple report. It can be read by each and every one of us, that when we have microcytosis, if we can simply look at these indices, Menser index, and we see that, okay, the RBC count is increased, then probably we start suspecting and do HPLC. Although if we are not a resource poor setting, we now recommend HPLC for everybody in the thalassemia belt, because India is within the thalassemia belt of the world. So I would like to know from Dr. Anita that is there a simple screening test for thalassemia that can be used on a large scale? Dr. Anita, you there? Or anybody else? Dr. Anita, are you there?
Yeah, I'm here. Yes, yeah. I'm audible now.
Yes, you are.
Yeah, we have a single rapid, simple cost-effective test, which is called NASTROF, means naked eye, single tube, red cell osmotic fragility test, which is a simple test, and based on the principle that these cells, microcytic cells, have reduced osmotic fragility when they are put in hypotonic saline 0.36, and they lyse quickly, otherwise they restore. So this is a simple test which we can do to detect NASTROF, and singly this test has almost 96% sensitivity. And if we combine it with our MCV, and which is less than this thing, so it is quite effective, and we can do that on large scale. We can go with this test.
Right. So thank you, ma'am. So I think this is a very important point that we have brought up here, that, again, it's a fact about low resource setting and a resource rich setting. If we have the means, let us do HPLC for all. But if we don't, then a lot of public hospitals, even in Delhi, they do offer NASTROF test for everybody. So this is in our own benefit, in the benefit of the patient, that we offer some kind of thalassemia screening to everyone. And I think it could be a matter of debate to a lot of people, but HPLC screening is desirable. It is desirable by all means that we do. So you see, the Menser index if the MCHC divided by the RBC count, if the RBC count is high, we know it's thalassemia. So the Menzer index is going to be low. So if it is less than 13, it is suspicious of thalassemia. So to make a diagnosis, so Dr. Ritu, would you like to just talk about some basic values? So the idea is that we go back with some number in the mind that, okay, if this is more than this, this is thalassemia.
Can I add something on this, please?
Yes, please.
Yes, yeah. If there is a severe microcytosis, I think that also hints towards thalassemia. That is looking at the CBC report. One is Menzer index, which you have mentioned, and one is MCV less than 60. I think severe microcytosis also points towards thalassemia.
Very, very good point. And I think this point came up in the earlier slide when we discussed that when would you like to additionally test for some additional conditions, and severe microcytosis was one of the features. So we should be aware of certain, indices in the CBC. When you have those, a raised RBC count of more than 4 lakhs or severe microcytosis, all of these are indicators that microcytosis is probably because of something else and not just iron deficiency anemia. So Ritu.
Yeah, for definitive diagnosis of thalassemia, I would like to go with that HB electrophoresis, and which works on the principle that there are the charged hemoglobins, they migrate at a variable rate in an electric field, and depending upon that, we can identify various types of that hemoglobin, and we can also assess their quantities as well. And depending upon the type and their level, we can identify different conditions. For example, the normal HB, the normal adult hemoglobin level ranges from 95 to 98, the minor adult from 2 to 5, and then the hemoglobin F from that, I think 0.5 to 2%. And if they are in the normal range, then we rule out this thalassemia. But if there is they are raised, any one of them is raised, accordingly we can identify the type of thalassemia. For example, if hemoglobin F is raised, we can say that this is the beta thalassemia. Hemoglobin A2 is raised, minor beta thalassemia, and so on. There can be other type of hemoglobins also, like the hemoglobin C, S, E, and yeah. So depending upon that, we can find out the cause of that.
Right. So the only thing that we need to remember here is that the HbA2 values, till the time that they are less than 3.5, we are happy. It's normal. But if the HbA2 is between 3.5 to 3.9, there could be thalassemia, and we need to start thinking about it. Because if it is with IDA, then it can be with beta thalassemia. With IDA, you can have values between 3.5 to 3.9. But the moment it is more than 3.9, you know that there is beta thalassemia trait. And more than 9, of course, there is a problem. But between more than 3.9, you know that it's a thalassemia, beta thalassemia minor or a trait. But 3.5 to 3.9, you can be having it if there is associated iron deficiency anemia. But less than 3.5, you're okay. So some basic numbers or understanding of HbA2, all of us should know. And if we look at the graph, it looks like this. The HbA2 comes here. The HbA is something that is the largest peak that it is forming. And these are the minor hemoglobins that they are showing. So HbF, HbA2, and HbA. So this is how the report will show. Now, so Dr. Harvinder, when should you actually do a hemoglobin electrophoresis? What are the conditions that you would ask for a hemoglobin electrophoresis? I would say ask in all. I would say that,
ideally it should be done in every antenatal patient. According to me, it should be done.
But there might be people who would say that, okay, it is debatable. So I would say like the theoretical question, but yes, which are the conditions?
It should be done in a patients who have a history of consanguineous marriage, especially. Then if the iron deficiency is not responding to, with oral iron treatment, microcytic anemia is if not responding to the iron. Then if there is history of hemoglobinopathies, hemolytic anemias, it should be done. At least electrophoresis should be done to rule out these.
Yeah. So generally, if there is a baby with hydrops, or there is some previously hydrops fetalis, right? Or there is some sickle cell, suggestive of sickle cell, in all of these situations, you will definitely do it, right? So this is something that you should definitely ask for this particular test, right? Now, I think that is all, because we are exactly on time and we finished in 1 hour. So I think we tried to cover all. Shilpi, would you like to, say something? And I would say that, we'll just take one comment each from our panelists, because this is something that is a topic which is very close to our heart. So Shilpi, starting from you, we can just take one comment from our panelists.
Stop sharing? Can you stop sharing?
Yes, ma'am.
Yeah, thank you, Dr. Parna. I think the key points we have already discussed, and after a approach-based, the reason-based approach to to eradicate anemia, first is knowing the cause, deworming, then iron supplementation, and diet is the take-home message.
Yeah, Dr. Vinita?
Yes. Yes, Dr. Parna.
Yeah, just one word to conclude, one comment from you to conclude the panel.
Yeah, Dr. Parna, it was a very nice panel, and all the points were well covered. And the carry-home message is also very clear, especially about the vitamin B12 supplementation, which is always a doubtful area in majority of the, especially the government hospitals. The private practitioners might be giving it, very as a routine, but in the government hospital, it is not being routinely given. So I think this is the best carry-home message for me, especially, and all the government places, people, that we will start giving this vitamin B12. Number two is that, yes, we will start screening for the adolescent anemia also coming to our OPD, especially those PCOS patients, those girls, AUV patients. We are doing the CBC for the anemics with AUV, but not for the all PCOS patients. So I think we will start doing that also. These are the two important carry-home
Right.
messages.
Thank you. Dr. Swati?
Can we have 5 minutes video in the end?
Swati is left.
Malti?
Dr. Swati?
Swati is left, Aparna.
Okay, Dr. Ritu?
Yeah.
And Dr. Yeah.
Yeah, ma'am. I would like to say, rather emphasize that our goal is to reduce the prevalence of anemia, and the evidence-based medicine may not be, we may not be able to implement it everywhere because of the low resource settings. And so what I have learned today is that we have to go for the oral iron trial. That should be I think encouraged at every level.
Right. Dr. Harvinder?
I think the most important thing is we should spend at least 5 minutes with the patient to counsel her, listen to the problem, why she is not taking the iron, and give her the dietary advice. That should be, at least we are giving, prescribing, we are writing, but we are not listening to the patient's problem, why she is not taking. We should spend 5 minutes with the patient and counsel her.
Right. Dr. Anuradha?
Yeah, 3 points from my side. Always have your antennas up with anything less than 12. Don't get satisfied with 10, 11, 8, 9. I think anything less than 12, you should have your antennas up, number one. Number two, don't forget the vitamin B12 part, because every second or third patient is vitamin B12 deficient. And don't forget the social factors. Like Dr. Harvinder has emphasized, spend at least 3 to 4 minutes and ask why she is not taking iron, or what is the actual cause. We keep on prescribing, and we are not talking to the patient. Even in our setup, where we have a OPD of something like 400 patients per day on Monday, I think if I spend 3 to 4 minutes, that is good enough. Thank you so much.
Yeah, thank you. So thank you, everyone. And I thank the organizers, Sharda Jain ma'am, DGF family, and Dr. Manjupuri ma'am, Shilpi, and all the panelists for a great discussion. Thank you very much.
Malti, can we have that 5 minutes video better?
I'm Dr. Sharda Jain, Secretary General of Delhi Gynecologist Forum. आज एक हम बहुत इम्पोर्टेंट टेस्ट कराना सिखाना चाहते हैं, जिसको हीमोग्लोबिन एंड पीसीवी एस्टिमेशन. जो हम रूटीनली अपनी क्लिनिक में करते हैं, क्योंकि जब लैब टेस्ट होती है उसमें रिपोर्ट 12 से 24 घंटे में आती है और इसमें हमें इमीडिएटली 5 सेकंड में ये रिपोर्ट पता चल जाती है। हीमोग्लोबिन क्यों इंपॉर्टेंट है? हीमोग्लोबिन हमारे हर सेल में ऑक्सीजन को ले जाता है। एक लेडी का हीमोग्लोबिन और एक लड़की का हीमोग्लोबिन 2 साल से ऊपर जो है महिला, उसका हीमोग्लोबिन 12 से कम नहीं होना चाहिए। जेंटलमैन और एक किशोर लड़के का हीमोग्लोबिन 13 से कम नहीं होना चाहिए। हिंदुस्तान एनीमिया का देश है, यहां पर हीमोग्लोबिन कम पाया जाता है और प्राय आप सुनेंगे अगर हीमोग्लोबिन लड़की का 8 ग्राम है, 9 ग्राम है, कहते ना चलता है, लड़कियों का चलता है। ये गलत है। WHO कहते हैं कि अगर हीमोग्लोबिन आपका ऑप्टिमल लेवल से ऊपर है तो आपको 90% बीमारियां नहीं होंगी। और हीमोग्लोबिन कैसा हो इसका हमारे ऊपर पूरा कंट्रोल है। हम अपना खान पान चेंज कर सकते हैं और अपना आयरन मेडिकेशन हम इसके साथ ले सकते हैं जिससे कि हमारा हीमोग्लोबिन जो है ऑप्टिमल लेवल पे आ जाए। अब आपको ये सिखाएंगे हीमोग्लोबिन और पीसीवी में रिश्ता क्या है। पीसीवी एक कांस्टेंट चीज है। आपका सुबह किया गया पीसीवी, शाम को किया गया पीसीवी, कल आपका पीसीवी किया, ऑलमोस्ट बराबर होता है। हीमोग्लोबिन 2 व्यक्ति आपका कर रहे हैं तो एक समय भी एक आदमी बोलेगा कि आपका हीमोग्लोबिन 11 है, दूसरा कहेगा आपका हीमोग्लोबिन 10 है, पर ये फ्लक्चुएशन पीसीवी में नहीं देखी जाती। इसलिए हम हीमोग्लोबिन को पीसीवी के साथ करें तो ये बहुत अच्छा है। हिंदुस्तान में यह बहुत छोटी सी मशीनें आ गई हैं, हर क्लिनिक में इसको यूज कर सकते हैं। लैब टेक्नीशियन और नर्स इसको सीख सकती हैं और आपको पेशेंट के ट्रीटमेंट में बहुत सहायक सिद्ध होता है ये सिंपल टेस्ट। तो हम जानेंगे हमें इसमें क्या क्या करना चाहिए। ये आप देख रहे हैं कि ये आपकी अल्कोहल स्वैब है, ये आपकी नीडल या जिसको हम लेंसेट कहते हैं वो है, ये आपका लेंसेट का एडेप्टर है, ये आपका सक्शन की टिप है जिसमें कि हम ड्रॉप ऑफ ब्लड को विड्रॉ करते हैं। इसके अंदर हमारी स्ट्रिप्स हैं और ये आपका हीमोग्लोबिन और पीसीवी एस्टिमेशन का मशीन है। प्रवीण साहब आपको इसको कर दिखाएंगे। सबसे पहले आप स्ट्रिप को लेते हैं और इस मशीन में फिक्स करते हैं, ये पहला स्टेप। दूसरा स्टेप ये, अब मेरी फिंगर को अल्कोहल स्वैब से साफ करेंगे। जरूरी नहीं आप अल्कोहल स्वैब लें, आप साबुन से भी, साबुन और पानी से भी इसको साफ कर सकते हैं, पर फिंगर का आपका ड्राई होना बहुत जरूरी है। फिर आप लेंसेट मशीन को लेते हैं। लेंसेट मशीन को में आपका एडजस्टमेंट है, ये 10 तक है एडजस्टमेंट, पर नॉर्मली हम लोग 3 से 4 के बीच में रखते हैं। इसका मतलब क्या है कि ये नीडल हमारे स्किन में कितना अंदर तक जाएगी, तो 3 और 4 में रखेंगे तो उससे अच्छी ब्लड की ड्रॉप आ जाती है और आपको किसी तरह की कोई परेशानी नहीं होती। मशीन इन्होंने ऑन कर दी, अब ये प्रिक लगा रहे हैं। अब इस कैनुला से, सक्शन से ये इसको ड्रॉप को ले लेते हैं, ब्लड ड्रॉप को, और आपने देखा कि इसमें एक जगह है, इसके ऊपर ये ड्रॉप को डाल देते हैं और इमीडिएटली आपको हीमोग्लोबिन का लेवल और पीसीवी का लेवल आ जाता है। आपने जाना कि मेरा हीमोग्लोबिन लेवल 11.8 है और मेरा जो पीसीवी है वो 35.2 है, तो इससे बहुत इंस्टेंटली, इमीडिएटली आपको पता चल गया कि हमारा हीमोग्लोबिन लेवल कितना है। तो आपने क्या सीखा कि हीमोग्लोबिन और पीसीवी टेस्ट इमीडिएटली बेड साइड पे किया जा सकता है, आपकी क्लिनिक में किया जा सकता है, आपके हर पेशेंट में किया जा सकता है, आपके हर एंटीनेटल पेशेंट में हर विजिट में किया जा सकता है। आपने ये भी जाना कि हीमोग्लोबिन लड़कियों का और महिलाओं का 12 से कम नहीं होना चाहिए।
मैम स्टॉप कर दीजिए.
मैम करें, कौन से मैम करें स्टॉप?
Now this machine is available for 3,500 rupees. And it has an accuracy of 95%. मेरी आप सभी से रिक्वेस्ट होगी कि इसमें इन्वेस्ट करिए और इसको स्ट्रिप की जो कॉस्ट है वो 20 रुपीज है. So I think, you know, each one of us should have it. It's very easily can be afforded by everybody, and I think everybody will be able to do it, and they will get an interest. We get it done in our clinic for all our staff, the hemoglobin level done, and they find there is a competition in them, you know, their hemoglobin has not fallen less than 12 gram%. And then once in a month, we get their relatives also, they can bring it over and we get it done. So I think this is a machine which everybody of us can definitely afford it. And by this, the nurses, the receptionists, everybody will know how to do it. I have today shared the number of this gentleman who will provide it for 3,500 rupees. And if anybody wants a sugar thing to be also done, this machine is free, but the strip will cost you 8 rupees for sugar. So I think it is worthwhile spending on this. And I think, you know, it should be a part and parcel of every private clinic. Every private clinic.
I have.
So may I take this opportunity to thank everyone
today, and we are looking forward that you will arrange a TOT workshop for 4. You will get it done for us, and the rest we will manage ourselves. So, Dr. Jyoti Bhaskar, you being
Meenakshi is
interested,
not there, so I'm going to take this honor of extending my deep gratitude and thanks to each and every faculty, each and every distinguished senior, our colleagues and friends, all who have logged in. I really do not know the number who has logged in, but it seems that since it was going on the Facebook and the messages I was getting that we are trying to log in, it must be enormous, and we have been able to take our message to everyone. So thank you, Dr. Manjupuri, as always, for enlightening us. And it's your passion, it's your dedication, and it's your work that actually has motivated each one of us over here. Aparna and Shilpi, it was a wonderful, very practical panel discussion. And I think each one of us has taken 1 or 2 points by which we can really change our particular practice. And Dr. Shada Jain and Dr. Sadhna, thank you so much for being with us always and for motivating us and really bringing all of us together on this particular platform. And to each and every faculty, thank you so much. And we'll see you all again on 9th of the next month.
Thank you.
9th of the next month, we will take up thalassemia on that day, because that thalassemia is again very close to our heart. And in a city of Delhi, 3,000 out of the 15,000 thalassemic are born. It means we are still not investigating our patients. And I will definitely go to Aparna that we must get it done. आप तो हम तो अपने lady का तो कराते हैं, तो gentleman का भी कराते. क्यों कराते? Because it is lifetime he has come to us. Doctor को investigation बता दो, so we get it done for him also. Because in case if he is positive, 50% of his children will be also positive.
Yes.
At that time he said, Doctor, हमारी कुछ investigation आप नहीं करा रहे, हमने कहा हम कराते हैं आपका. So that is it. Because that is time they are receptive. We be getting an HIV done for his wife. He said, "ऐसे आप तुम्हारे इस बहाने चलो तुम्हारा भी करा देते." So he gladly gets it done.
Right.
Madam, male health is getting neglected too much, because for women we are having advocacy in the persons like you and Dr.
नहीं मैडम, male health तो आपके जैसे लोग grandmothers ने खराब कर रखी, डॉक्टर साहब, हमारे ladies को neglect कर रखा है. नहीं डॉक्टर, we've been over neglected. It's time that we must get our dues. And here again I will tell you, ये सारी politicians, they are doing only lip service. When this gentleman Modi is trolled for malnutrition, then only he is leading. कोई भी anemia के लिए थोड़े ना ये अपनी किट्टी खोलता. Anemia is neglected, doctor. Not what a woman is neglected as such.
Yes, that is it. But what I see in infertility clinics, they are anemic, they are having so much of problems, they are hypertensive. So we think
Dr. Sadhna, problem
yes.
is with us. Problem
yes,
is with us. हमारे अपर्णा जैसे लोग होने चाहिए बोलने के लिए कि क्यों नहीं कराओगे थैलेसीमिया की टेस्टिंग. भाई आप बोलोगे तो डॉक्टर सब कराएंगे. कुछ भी पैसे की कमी नहीं है आज की तारीख में.
Ma'am, conviction is on our side. Are we convinced enough?
हमको ये बताना चाहिए कि ये हीमोग्लोबिन जो आपके आयरन की गोलियां मिल रही हैं ये इक्वली अच्छी है जो बाजार में मिलती है. अगर मेरे को चॉइस मिले तो ये वाली टैबलेट इज मच बेटर देन. हमको बस एक ही सेंटेंस बोलना है, हमें दूसरा सेंटेंस बोलने की जरूरत ही नहीं है. मैं एक स्टैंप लगाओ डॉक्टर मंजूपुरी, यू स्टार्ट पुटिंग स्टैंप कि जो सरकारी दवाइयां हैं ये प्राइवेट दवाइयों से बेटर है. हम देख लो, लुक एट द कंप्लायंस. अब बस एक स्टैंप लगाओ डॉक्टर. मैं बता रही हूँ डॉक्टर साहब, दिस इज व्हाट इट इज. नहीं तो वो नाली में फेंक कर जाती है डॉक्टर साहब. आप डालोगे ना उसमें स्टैंप लगाओगे तो स्टैंप कॉस्ट करता है मनी डॉक्टर साहब. दे अंडरस्टैंड द इम्पोर्टेंस ऑफ इट. और हिंदुस्तान बदल गया है डॉक्टर साहब. मुझे अच्छी तरह याद है कि डायरेक्टर जनरल ऑफ हेल्थ सर्विसेज से मैं टैबलेट्स लेने गई when we used to work in slums in 2000. So she told me, she was from All Indian Institute of Medical Sciences. She said, Sharda तो अपना नाम खराब करेगी ये टैबलेट देके. But now it is not the same.
Not the same.
Things have changed.
Yes.
So I think with that note, we take leave of everyone, and we'll meet again the next month.
Thank you so much.
I'm sure that 9th of February you will enjoy thalassemia thing. It is going to be wonderful. Every month you're on the 9th, you'll hear on anemia and something with a better note. Today you have heard about the diagnostic part from Aparna and Dr. Vinita Vain, but I think it is going to be still better deliberations in future. So people who want to participate should definitely opt for it. Give their names to Dr. Jyoti Bhaskar. She will be able to coordinate with you all. Thank you very much, Dr.
Thank you.
Thank you very much, Dr. Manjupuri.
Thank you, everyone.
Thank you.